Hello all. So welcome back to Gynae Wizard Placenta series, and today we are discussing about immunology of feto-maternal interface. So this immunology is very much important, and yesterday I posted in my channel that whenever there is the interaction between the fetus and the mother and there is immunotolerance, only then there will not be any rejection of the fetus, because we all know that the fetus is a semi allograft. So why it is called as a semi-allograft? Because 50% of the genetic material is from the mother plus 50% of the genetic material is from the father. So that is why, because of the paternal antigens, it acts like a semi-allograft. So because of this, there might be rejection of the fetus when there is implantation. But there are beautiful changes which occur in the trophoblastic tissue and in the decidua, which help the mother to know that this fetus has to implant, and all the favorable factors of immunology will play a role. So then the fetus will be successfully implanted and then the pregnancy continues. But if there is any problem or if there is any immunological problems which are associated, that time it might lead to recurrent pregnancy losses, or sometimes if it is an IVF conception, it might lead to recurrent implantation failures. So today we will understand the basics of immunology, and in my future videos I'll be discussing its clinical implication in the field of infertility as such. But today we will discuss the basic immunology which happens at the feto-maternal interface. So without further ado, let me continue. So when the fetus is a semi-allograft, this has to go and get implanted into the uterus. So this has to happen. So what happens at the secretory phase of the cycle, that is secretory phase of the menstrual cycle, whenever the implantation is expected, the lymphocytes or leukocytes will increase in the endometrium. So these leukocytes will be comprising of three types of cells. Firstly, the uterine NK cells. The second one is the macrophages, and the last type of cells are the dendritic cells. So these uterine NK cells these are the largest population, accounting to about 70%, and macrophages around 20 to 28%, and dendritic cells about 2 to 3%. And only if this ratio of uterine NK cells, macrophages and dendritic cells is maintained, then only the implantation might occur. So this uterine NK cells, which I will be in detail discussing today, is very much important, because these NK cells, they are like a transition between the innate immunity and the acquired immunity. So these cells have a cytotoxic effect, but during pregnancy or when the implantation is about to happen, they regulate the trophoblast invasion and proliferation and help the pregnancy to grow on. But if the NK cells are less, implantation will not occur. If the NK cells are more also, the implantation will not occur, because when the NK cells increase, the inflammatory milieu inside the endometrium will also increase, and this is not favorable for implantation. So that is why in the recent period, we check for the uterine NK cells, or how much percentage of cells are present. So if they are very high, that is one of the indication for it is one of the reason for recurrent pregnancy loss or recurrent implantation failure as such. So that is why this immune balance is very much necessary for the pregnancy to occur and also continue. So this is what is important with respect to immunology during pregnancy. So yesterday I asked how many feto-maternal interfaces are present. So we have to remember that there are 5 types of fetal and maternal interface. So what do we mean by an interface? It is a bridge between the fetal components and the maternal components. To be very to be very clear, between the fetal circulation and the maternal circulation, there are certain barriers. So these are called as fetal or maternal fetal interfaces. So these are five in number and each one has its importance. So the first interface occurs between the maternal blood, which is coming from the spiral arterioles into the intervillous space. And between this blood in the intervillous space and the syncytiotrophoblast, there is a interface. So this interface, it's not a watertight barrier. So some of the immune cells might move from the maternal circulation to the fetal circulation. So this is the very important reason for microchimerism. So what do we mean by microchimerism? It is the presence of one type of genetic cells in another's body. So this fetal microchimerism is very much noted that the maternal immune cells enter the fetal circulation and they can get deposited into various cells, and it is the same, it is opposite also. Certain fetal cells also enter into the maternal circulation. So that is why we speak about giving anti-D in an Rh negative mother, because the maternal Rh, the fetal antigens, Rh antigens might go into the maternal circulation and invoke a immune response. So that is why this is not a watertight medium and it has certain diffusion of cells from this side of the circulation to that side of the circulation. So this is the first interface. The second interface is between the decidua. So this is the endometrium and this is the decidua. So decidua is nothing but the endometrium of pregnancy. So the decidua, in between the decidua and the extravillous trophoblast. So these extravillous trophoblasts which are coming, so these are also having a interface between each other. The third is between the maternal blood and endovascular trophoblasts. So these endovascular trophoblasts will invade the spiral arteries and these spiral arteries are converted into low resistance and high capacitance vessels. So there is a barrier between the maternal blood inside the spiral arteries and the endovascular trophoblasts, which are the component of the fetus. So that is the third interface between the maternal blood and the endovascular trophoblast. And the fourth is between the maternal circulation, that is the entire maternal circulation, and the extracellular trophoblastic vesicles. So what are these extracellular trophoblastic vesicles? This trophoblastic tissue, it sends out all the toxins or unwanted products by something called as exocytosis. So there is the protrusion of this trophoblastic tissue, that especially the syncytial knots which we discussed in our first class. So the trophoblast forms syncytial knots to throw away all the waste material from inside to outside. So these vesicles might enter into the maternal circulation also, and this is the fourth maternal and fetal interface. And lastly, the fifth feto-maternal interface is between the decidua. So between the decidua of the endometrium and the amnion and chorion of the fetus. So this amnion and chorion, these membranes are attached to the decidua. So this interface between the decidua, that is the maternal component, and the amnion and chorion forms the fifth interface. So that these interfaces, why are they important? Because I already mentioned these are not water tight, so there might be shift of immune cells from one side to other. So this might invoke a immune response, and if the immunology is not maintained properly, it might lead to abortions or recurrent implantation failures. So that is why this feto-maternal interfaces is important. So now we'll discuss about what are the various immunological aspects during pregnancy. So today we are just discussing the basics of immunology. So what is it? So firstly, we have to understand that pregnancy is a Th2 phenomenon. So we all know that there are two types of cells. So especially the leukocytes, there are two types of cells which are present. So there is something called as Th1 and there is Th2. So these are two types of cells which are CD4 plus cells. So CD4 T helper cells, So under CD4 T helper cells, there are two types of cells. So that is TH1 and TH2. So this TH1 is inflammatory. So it has more of, it's like pro-inflammatory. So this releases the cytokines and chemokines, that is TNF, interferon gamma, IL-2, IL-12 and IL-18. So all these induce an immune response, and this is mainly helpful in cellular defense. So whenever there is an antigen, so these are activated and these cytokines are released, and cytokines are released, and it leads to cytotoxicity of the cells, and these might then be phagocytosed by the macrophages. So this is how this acts. So this is nothing but the TH1 response. So what do we mean by TH2 response? So it is anti-inflammatory, or it is more of a humoral response. So this is more of a cytotoxic. So this is more of cytotoxic response, but this is mainly more of a humoral response. So what do we mean by humoral response? It mainly releases the B cells or the plasma cells which produce antibodies. And these antibodies are very much essential for what? For trophoblast invasion, proliferation, and finally the implantation of the embryo. So once the embryo is implanted, then the trophoblastic invasion and proliferation will occur. So this is very much important, and this TH2 response is necessary for maintenance of pregnancy. So what is important with respect to these immune cells? And next, there are certain immunoregulatory factors which help in implantation, and there are certain hormones of pregnancy which are absolutely necessary for the implantation to occur. So first we will discuss all of these one by one. So firstly, the immune cells. So amongst the immune cells, I already mentioned there are certain cells called as a T regulator cells. So these are also very important, and they express CD4, CD25, FOXP3, and these increase during the first trimester. And these T regulatory cells are very much important for the trophoblastic invasion and proliferation. So you remember TH2 response, whatever is forming during pregnancy, has three main functions. Firstly, it helps implantation. So it will have that crosstalk between the embryo and endometrium will occur, and this crosstalk is mainly because of the chemokines, and thus the implantation occurs. The second, the trophoblastic formation and proliferation occurs, and third, the trophoblastic invasion of the spiral arteries also occur. So all these three functions are necessary for the establishment of pregnancy and progression of pregnancy. But if any of these factors are absent, this might lead to the abortions, or if the trophoblastic invasion is deficient, it might also lead to preeclampsia and IUGR, as you already know. So these T regulatory cells are very much important for the implantation to occur, and especially during the first trimester, their concentration increases, and this is very much important. The second type of cells are gamma delta T cells. So these are present in about 1 to 10% of the population of the total immune cells, and they release TGF beta. So this beta is very much important for an anti-inflammatory or TH2 shift. IL-1 beta, IL-6 and IL-10 are released. So these cytokines are released, and once these cells, they express something called as CTLA4 antigen on the surface. So whenever they express the CTLA4 antigen, they have an inherent capacity not to get phagocytosed or uh, not to get damaged by the activity of the cytotoxic cells. So these cells are also very much important for the implantation to occur. Let's come to the natural killer cells. So in the natural killer cells, I already mentioned, so there are two types of natural killer cells or NK cells. One is the peripheral type of natural killer cells, and the second one is uterine type of natural killer cells. So these peripheral NK cells we are not interested in. We are mainly interested in the uterine natural killer cells. So these cells they express a molecule called CD56 bright and CD16 minus. So these are very much important and these are present in the uterine milieu. So in the uterine or decidua, this uterine NK cells are very much important. So we can notice these NK cells close to the extravillous trophoblast and the maternal spiral arteries. So these uterine NK cells, they release chemokines, especially IL-8, interferon, gamma, and SDF1. And they also have angiogenic factors such as VEGF, and placental growth factor is also released. So all these good factors will help in remodeling of the spiral arterioles. So whenever there is remodeling of the spinal arterioles, there is immune tolerance and thus the invading of the trophoblastic cells will occur, and this might also prevent preeclampsia in the future. So that is why these uterine NK cell activity is very much important, and as I stressed before, if the activity is too more also, it is a problem. So it should be optimum between a range of 60 to 70%. So these NK cells are very much important in the immunotolerance state. This next type of cells are CD4, CD14 plus cells, are also called as the monocytes. So what are all CD14 plus cells? Monocytes, macrophages, Langerhans cells, and neutrophil granulocytes and B cells. So these express CD4, 14 and CD68, and these are very much important for the phagocytic activity and immune reaction. So these cells are also important for spiral artery remodeling and trophoblastic invasion. And amongst the macrophages, again, there are divided into M1 macrophages and M2 macrophages. So M1 is always pro-inflammatory and M2 is always immunoregulatory. So these immunoregulatory macrophages are very much uh, necessary. So that is why, so I'm practicing infertility, and many of my IVF patients, we don't know the cause for recurrent implantation failure. So one embryo transfer failed, the second embryo transfer failed. So we have evaluated them, done a hysteroscopy, ruled out chronic endometritis, and all the other components of implantation failure have been ruled out. But what is not ruled out is the immunological, because immunological we don't have current evidence that these are the panel of tests which are recommended. So the recent ESHRE tells that none of these panel immunological profile is recommended because they are not very evidence based. So they try to do an immunoregulatory function by giving other medications like HCQ, and that is hydroxychloroquine, and they give progesterone, and they give low dose steroids, and they give some um, uh, chemotherapeutic drugs like tacrolimus. So all these have a anti-inflammatory state, and they evoke a Th2 immune response, and this might help the patient to conceive and continue her pregnancy. So that is why we require a immunoregulatory state and not a pro-inflammatory state. So I cannot tell that anti-inflammatory state is necessary for pregnancy, because even if there is no inflammation, if there are no good cells, so all these good cells which I spoke to you right now, that is the T regulator cells, the CD14 plus cells, the uterine NK cells, and the gamma beta cells, all these are very much important, and if these cells are in right proportion only, the pregnancy will occur. And if there is anti-inflammatory, it does not occur. So that is why we can tell that there should be a good amount of immunoregulation which occurs for the pregnancy to continue. So these are the very important cells which are helping in the trophoblastic invasion and the trophoblastic proliferation, and this is important for prevention of abortions and preeclampsia. Next, coming to the immunoregulatory factors. So what are the immunoregulatory factors? So we all know that the extravillous trophoblast will express the HLA-G antigen. So we all know that the major histocompatibility, there are two classes, class 1 and class 2, and this HLA-G is very much important, and they belong to class 1B, and these are very important for immunoregulatory molecules. So this class 1B HLA-G, so this is expressed by the extravillous trophoblast. So these have a immunoregulatory action, and this is very much important for the implantation to occur. Finally, there are certain hormones also which are necessary for the immunoregulatory function. So we all know there are different hormones. So I told you different hormones produced by the placenta, which we discussed in our last class. So estrogens, progesterones, glucocorticoids, everything are important. But amongst them, two important hormones are very much important for the establishment of pregnancy. So the first one is the progesterone. So progesterone is very much important, and this progesterone will be, firstly I told you the corpus luteum will release the progesterone, and then the luteoplacental shift happens by 8 weeks, and the placenta will be producing the progesterone. So all these progesterones, these progesterone will act on the leukocytes. So many leukocytes, they express the P4 receptors. So what are the leukocytes which express the P4 receptors? The lymphocytes, the macrophages, the dendritic cells, all these will have a P4 receptors. So because of this expression, they induce something called as, they induce leukocyte inhibition factor and macrocyte colony stimulating factors, and these two are very much important for the successful implantation to occur. So this progesterone releases these two factors which is required for successful implantation, and the Th2 shift also occurs. So this is called as the immunomodulation. So this immunomodulation is a very important function of progesterone. And the third important function of progesterone is the production of HLA gene, G production, and that is why this also has an immunoregulatory function. And lastly, it produces PIBF, which also helps in shift to Th2 cytokines. So this PIBF, this inhibits the degranulation of the mast cells and NK cells and the cytotoxic activity, and it will have a more of humoral response, that is it will have a Th2 shift. So these are the different functions of the progesterone hormone. And the second important hormone is the human chorionic gonadotropin. So this is very much important, and this is also necessary for the production of VEGF, for all the angiogenesis to occur. And this angiogenesis, it helps in formation of new maternal spiral capillaries and arterioles, and the trophoblastic differentiation and the migration, and it also increases all pregnancy supportive cytokines and growth factors like macrocyte colony stimulating factor and leukocyte inhibitory factor. So all these are very much necessary for the immunomodulation to occur. So this slide is the snapshot of whatever we have discussed in today's class. So we have the anti-inflammatory factors which are releasing from the placenta, which are very much important for immunoregulatory function in the feto-maternal interface. And if this TH2 shift and if this milieu is maintained, this immunological milieu is maintained inside the decidua and the fetus, only then the successful implantation and the proceeding of the pregnancy will occur. So, in conclusion, the progesterone secretes PIBF, HCG, even PG. Prostaglandin E2 is important, and all the TH2 cytokines, that is IL-4, 5, 6, 10, 13, and TGF beta. And I already mentioned these four types of cells which are very much important, that is gamma delta T cells, T regulatory cells, uterine NK cells, and M2 macrophages, and also the HLA class 1B, that is HLA G, E, and F are important. And there is something called as the Fas and Fas ligand. So this is something which ensures that the apoptosis occurs. So this Fas is expressed by the maternal immune cells, and Fas L is expressed by the syncytiotrophoblasts. So this apoptosis can occur if there is any interaction. But this Fas and Fas will not occur because there is a protective component called as a BCL2 anti-apoptotic protein. So this anti-apoptotic protein is very much important for the prevention of interaction between the Fas and the Fas L ligand. So Fas is present on the maternal immune cells. Fas L ligand is present on the syncytiotrophoblasts. So this has to not interact with each other. So this is prevented by something called as BCL2, which is also released from the placenta. And there is something called as the galactin-1, which also ensures the release of PIBF and prevention of cytotoxic activity. And these extracellular vesicles which might uh, phagocytose what are the immune cells which are present, and they might throw them into the maternal circulation, is also important to prevent the immune rejection or the fetal graft rejection. So these pro-inflammatory are decreased, and what are all decreased? The TH1 cytokines, helper cells, cytotoxic cells, M1 macrophages, and the normal peripheral NK cells. And HLA class 1A, that is A and B, are also decreased. So there is enhancement of the class 1B antigens, and that is very much important for the immunomodulation to occur. So finally, I want to end this class by talking some clinical implication of this reproductive immunology, because this is very much important. So as day in and day out, we are dealing with lot of infertility cases, and I'm doing IVF. So I face issues with recurrent implantation failure. So whenever there is recurrent implantation failure, we will evaluate both the male partner and the female partner. And once the male partner is evaluated for HSA, that is, HSA is normal, DNA fragmentation is normal, and no comorbidities, karyotyping is done, and everything is ruled out. And in the female, we have ruled out all the anatomical defects, and we have also ruled out any endocrine disturbances like hypothyroidism, hyperprolactinemia, diabetes mellitus, and if there is any APLA, all these we have ruled out. And then we have also done a hysteroscopy and ruled out chronic endometritis. So once we've ruled out everything, but what still there is an implantation failure, this might be due to immunological cause. So whenever there is immunologic intolerance or immunological imbalance, and this immunomodulation does not occur, that time there might be chances of implantation failure. So this, when everything is normal, it looks very idiopathic. That might be one of the cause. This immunological cause might be one of the cause. So we have various treatments nowadays. We have intralipids, we have steroids, we have IVIG, we have tacrolimus, we have HCQ, we have thymosin alpha. So all the gynecologists who are practicing infertility have come across all this, especially IVF cases. So whenever we are suspecting an immunological cause, so these are all like an empirical therapy. So according to ESHRE, none of these is recommended. So nowadays HCQ is recommended as it acts and it has some of the immunomodulation factor. But what actual function of all these drugs is mainly they all go and they help in maintaining the immunological milieu, especially with respect to the uterine NK cells. So this uterine NK cell activity is kept optimal by these treatments. So these still are empirical, but still there is much research should be conducted to tell actually whether these drugs or these treatments are necessary when we are suspecting a immunological cause. But presently, the only two drugs which are slightly helpful in recurrent implantation failure. So these might have at least 15%, 10 to 15% benefit, and that is it. And HCQ is proven to have some benefit in immunomodulation, and even progesterone has immunomodulation. And this thymosin alpha, this helps to calm the T cells. So it calms the cytotoxic T cells, and this also helps in immunomodulation. So that's why immunology is very much important, and if you don't know the basics of immunology, especially the reproductive immunology, we will not be able to explain abortions, recurrent pregnancy losses, recurrent implantation failures, preeclampsia, and other immunological conditions like APLA, ANA positive, anti-TPO, antibody positive. So all this we will not be able to explain. So that is why a detailed immunological evaluation is also necessary when we are dealing with recurrent implantation failure. So with this, I conclude this session. So you have to know the immunological aspects in the feto-maternal interface, which helps in the implantation and successful pregnancy outcomes. Okay. So keep watching Gyne Wizard. Thank you. Have a nice day.